that Dr. Dunk went over again. You know, where you set up, taking out the joint, the skin slag here, applying your weight down on it, and then thrusting. Problem is, as we get higher up in the thoracic spine, if I were to actually thrust, watch what happens to Sarah's head. See how it goes into extension? So you don't want to cause whiplash to a patient who you're trying to help feel better. So the idea behind the modified cross bilateral is that if you can support and stabilize the head, then you are able to do a cross bilateral. That's basically the whole spiel. So come sit up for a second now. I'm going to face this wall. So this specifically is for rotation fixations from T1 to T3. And of course, just to remind you that as you are going through your motion palpation, you are starting from the top, working your way down on this side, starting your way from the top here, working your way down on this side, making your notes accordingly, formulating a treatment plan, and now it's time to adjust. But for the sake of argument, I'm focusing specifically between here and here. Cross your arms for me. That's good. So, standing ipsilateral to my contact. So my thumb is on the side of the spinous process, ipsilateral to the side I'm standing in. I'm going to get in close. I'm going to rotate my patient into me. The spinous process should rotate away as I'm rotating my patient into me, but there might come a point where it rotates like this, where you feel an increase of pressure on your thumb. Tender?
A little. My back's kind of
messed up.
Oh, yeah.
And of course, see how I switch sides, because of course you want to evaluate one side with respect to the other. Okay, so on Sarah, at T3, when I rotated her this way, the spinous process should have moved this way. Instead, it came into me because I felt an increase of pressure. So what is that, PR or PL? Spinous process is?
R.
It's a PR listing. The process is right. Spinous process is right. So if the spinous process is right, which transverse process is most posterior?
Left.
The left. Okay. So I'd be setting Sarah down on her tummy and setting up on the TVP on the left. Now, because that means I'd be blocking all of you, I'm not going to actually adjust that spot. What I'm going to do is I'm going to turn around, and I'm going to pretend for the sake of argument that we had a PL listing, and now I'm setting up on the right because the right spinous process is elevated. But you understand how I got there, right? Okay. So, starts off looking exactly like a cross bilateral. So there's nothing elevated. I'm probably not going to get cavitation because the problem's on the other side. However, let's do this anyway. I'm going to pick a spot. So let's pretend it's T2. Okay? T2, here's the transverse process. You guys have already seen cross bilaterals. You've already done it. So please start me off on this process. So, what do I do?
Switch hands.
Well, this is my marking hand. So,
right.
So yes, the hand that's closest to the table is the one that's going to be the adjusting hand. Which part of my adjusting hand is going to be contacting the TVP?
Pisiform?
Pisiform. Pisiform is going to contact. Do I just put it on like that, or do I do something first?
No, take out the skin slack.
I'm going to take out the skin slack. I can do that in a bunch of different ways. Dr. Dunk showed you a few. I showed you a few. You can either mark that spot with your adjusting hand. With your non-adjusting hand, you can slide the skin cephalad, and then with your pisiform, slide onto the TVP. Or what you can do is come right down onto the TVP like this, apply a P to A pressure, and twist. Or you can do whatever combination your heart desires, just as long as you are on the TVP and you're not slipping anywhere. Okay, this is where things start to differ now. So normally in a cross bilateral I would do this and then have a breathe in and breathe out and adjust. This is where things become a little bit different. First thing that I notice that's different is that I feel not stable. I feel like my hand is going to slip right off her shoulder if I stay in this position. So what I need to do immediately to make myself feel a little bit more stable is pivot myself forward. So I'm not going over my contact site yet. I'm just moving my hand forward because otherwise I'm afraid I'm going to do this. Okay? So I just have to move myself forward a little bit. If I don't feel like I'm going to slip, I don't have to move myself forward. But if I feel like I'm going to slip, I'm just going to move myself forward to anchor myself. I feel more secure. Now, instead of moving over like this, what I'm going to do is I'm going to protect her head. The headpiece is neutral or slightly below neutral. What I'm going to do with my crossing over hand is, you can take a look at this here too, Sarah. With the web of my hand right here, I'm going to contact her occiput. Pretty much, I'm going to show you on the opposite side because it's going to be on this side. See here, sort of between the ear and the center of the occiput, the web of my hand is going to contact just underneath the occipital rim. That way I have the ability to control her head. I'm going to be doing it on this side though, of course, because this hand is going to be busy setting up. So I'm going to get a little bit forward. This hand is going to contact just underneath the occipital rim. And eventually what I'm going to be doing is I'm going to be turning and tractioning the head to stabilize it. So this is what I'm going to be doing at the end. Turning and tractioning the head. But right now I'm just hanging out because, of course, if you're futzing around for a minute while your patient's head is turned and tractioned, eventually what's going to happen is they're going to tell you to get lost because you're hurting them. So I'm just going to hang out here. My hand is, the web of my hand is right on the occipital rim. Now, Sarah's going to take a breath in and a breath out. And then you're going to breathe regularly. Now, on the breath out, what I'm going to do is I'm going to pivot my body precisely the same way as I did in a cross bilateral. So I'm going to be moving my sternum over my contact site so that I'm applying weight on my pisiform and I'm going to start sinking down on it. At the same time as I turn and traction the head. Looks like this. Breathe in, breathe out. Okay? So, you can sit up for a second. So I've got my, 1, 2, I was here. So, breathe in, breathe out. Okay, so I'm doing this, and now it's time to thrust. The thrust is specifically going to be with the hand that's the pisiform that's contacting the TVP. This hand is totally stable. And the thrust is the 3 things that I showed you last week. It is the spider crawling on your finger, ooh, at the same time as you bow, at the same time as you drop on your leg. So, 1, 2, 3, like you're doing one-handed CPR, ooh, okay? Okay? So, let's see how it looks in real life. We're probably not going to get cavitation because it's not a problem. Okay, Sarah, breath in, all the way out. Like that. Okay, now let's show Sarah. Come sit up. Thanks, Sarah.